which we are holding in commemoration of the World Hepatitis B Day, which is actually tomorrow. So our presentation is quite timely. Our presentation will cover the topic of achieving the WHO's 2030 hepatitis B and C, elimination goals. And we'll get to hear about what progress has been made and what more is needed. So I'll go ahead and introduce our speaker. She's Lindsay, I hope I've pronounced your name correctly, Hybert, who is an Associate Director for the Coalition for Global Hepatitis Elimination. Her role in this NGO is related to technical assistance, operational research, advocacy, and policy to advance hepatitis B and C elimination globally. And prior to this, she has been a program officer at Faro's Global Health, where she managed collaborative projects in South Africa, Indonesia, Senegal, Malaysia, Morocco, quite a number of countries. And these projects involved viral hepatitis programs, strategic planning, investment and development, as well as epidemiologic program and economic modeling, a lot of things. So Lindsay, go ahead, welcome. You can start your presentation.
Wonderful. Thank you so much, Dr. Juma, for that introduction, and thank you for the invitation to join you today. It's a true honor to present to this impressive webinar series, and especially on World Hepatitis Day. As Phoebe mentioned, my name is Lindsay Hebert. I'm the Associate Director at the Coalition for Global Hepatitis Elimination. And today I really want to share with you more about the policy and public health situation on hepatitis elimination. My background is not in clinician, I'm not a healthcare provider. It's really in policy development, in program analysis and health economics, and helping governments stand up and follow through on their commitments to these hepatitis B and C elimination goals. So I'm really excited to share with you today. And I hope after this webinar, you'll see there's much to be done, and I hope it'll lead to more collaborations, especially in Kenya, where we haven't had much data or as many initiatives as we'd like. So hopefully that'll change in the future. So just to get started, again, just want to thank you for honoring World Hepatitis Day. This is a global movement that's celebrated every year on July 28th. There is a whole website that's managed by a patient network called the World Hepatitis Alliance, where you can go and download your own materials for World Hepatitis Day. If you just search World Hepatitis Day, it should come up. But here's one of our graphics that we'll be sharing tomorrow. And these are my disclosures. The coalition receives a number of grants and resources from diverse sources. So today I'll just introduce the global hepatitis B and hepatitis C elimination goals established by the World Health Organization and endorsed by the World Health Assembly. I'll walk through what the coalition calls the essential components of effective hepatitis B and hepatitis C elimination programs, and share updates on where different countries are in putting in place those different components, specifically looking at strategic information, prevention, testing, and treatment policies, equity, and financing. And then I'll end with just resources that the coalition has developed in the hopes that it can be helpful for programs, both at the national level, but also at the micro level in terms of hospital systems or provincial programs to establish elimination initiatives. So just to set the stage here, hepatitis B and hepatitis C are major public health problems that are very much neglected globally, given the immense burden. For hepatitis B, very few people realize that about 300 million people are living with chronic hepatitis B globally. The regions with the greatest burden include the Western Pacific region, the African region, and the Southeast Asia region. And about 1 million deaths, almost 800,000 deaths per year occur. Currently, the major routes of transmission for hepatitis B are perinatal and horizontal contact in young children. With this in mind, about 6 million children under 5 are living with hepatitis B, and about 2 of 3 of these children are African children. So just for your context here. In terms of hepatitis C, a smaller burden than hepatitis B, about 60 million people are chronically infected globally, about 300,000 deaths per year. And currently the major routes of transmission are healthcare associated transmission, on sterile equipment, etc., as you are, I'm sure, all very familiar with. We also see a very high prevalence in key populations, including persons who inject drugs, and in countries where injection drug use is a public health concern. Hepatitis C is also a priority there. In terms of the global distribution, the highest prevalence we see in terms of absolute numbers in the European region at 12 million persons, but also similar burdens across the African, Eastern Mediterranean, Southeast Asia, and Western Pacific regions at about 10 million persons in those regions. When we look in the African region, here's a snapshot of some select countries where we are able to have available data for hepatitis B. It really varies across countries. In Ghana, it's estimated to be as high as 12%. The latest studies have estimated between 8 to 12%. In Kenya, the most recent population impact survey for HIV included hepatitis B, and that estimate from 2018 was about 3%. For hepatitis C, the prevalence ranges anywhere from a little under 1% in Rwanda. Ghana also estimates a prevalence of up to 3% for chronic hepatitis C. I was not able to find any national estimates of hepatitis C in Kenya, but there was a recent study that estimated the prevalence among persons who inject drugs along the coast in particular was about 13%, and also in some of the urban settings. So perhaps a high burden among persons who inject drugs throughout the country. So hepatitis B and C are major public health concerns because of how they infect the liver and lead to long-term liver disease. We face a unique problem in hepatitis elimination because the impacts are delayed. People can be infected quite young, as we see with hepatitis B, but they may not see the impacts of that infection in their liver for 20, 30, 40 years as that liver disease advances to cirrhosis, and perhaps even liver cancer. And so this delayed time frame makes it less of an acute problem for policymakers, but it's our job to convince them that we must prevent this from happening, because in most cases, once people are diagnosed with severe liver disease, there aren't many options to prevent it to continue to advance. So this is a real public health problem to prevent that severe liver disease from happening in the first place. Currently, about 2 out of every 3 liver cancer deaths are associated with hepatitis B and C infection, and liver disease or liver cancer is the 4th most common cancer globally. About 40% of liver cancer is associated with hepatitis B globally, and about 30% hepatitis C. So in terms of new infections for hepatitis B, as previously indicated, the majority of new infections are associated with mother-to-child transmission and horizontal transmission, and the majority of these cases are happening in the African region. About 2 out of 3 new hepatitis B infections are in the African region, and this has been a major focus of the coalition, as I'll talk about further. But just as a teaser, the real priority here is introducing the hepatitis B birth dose vaccine, so monovalent vaccine under 24 hours, within 24 hours of a newborn being born. After being born, this vaccine should be administered to help prevent the transmission from mother to child, and then followed by the series that has been introduced in all countries, the 3-dose series. In terms of mortality trends, this graph here just shows the absolute number of total deaths globally. And here we see that the burden of hepatitis B mortality is predominantly in low and middle income countries. When we look at absolute numbers, we see China, India, of course, but then Indonesia, Nigeria, Egypt, Pakistan, Thailand, and then we do also have a few high-income countries as well. Korea, Japan, the United States also fall in here. So this really is a true global concern. Majority burden in low and middle income countries, but at the coalition, we believe that we can share lessons across across the world because hepatitis really affects everyone in every society. And similar trends for hepatitis C as well. So this graph here is really one of our key messages that unlike other infectious diseases, tuberculosis, HIV, malaria, which we're all very used to talking about, hepatitis B and C are not moving in the right direction. For these other diseases, we see trends going down over time, given huge investments from initiatives like the Global Fund and PEPFAR and commitments of national governments. But hepatitis B and hepatitis C have not benefited from the same global awareness and political commitment. So currently, deaths from these diseases are projected to go up unless we intervene and introduce key interventions. So for many years, there were not elimination goals for hepatitis B and C, but what made these goals possible, because very few diseases qualify under WHO definitions of eligibility for elimination, was the introduction of hepatitis C cures. These were a revolution in medicine, the first oral pills that could be delivered to cure a chronic virus. And the scientists that discovered the hepatitis C virus actually received the Nobel Prize for their discovery that led to this breakthrough in modern medicine. So with the combination of a cure for hepatitis C and the hepatitis B vaccine, which we've had for many years now, these two diseases now met the eligibility for WHO elimination. The first WHO elimination goals were set in 2016, and in 2022, these goals were updated. Here's a link to the WHO strategy, which I'm happy to share, but just to make you aware that there are specific targets that countries are asked to achieve to be able to be verified for elimination. There's impact goals to start with. And WHO is looking for reductions in new infections. Currently, there's an absolute target for reducing to 5 per 100,000 by 2030 for hepatitis C and 2 per 100,000 for hepatitis B. And then for mortality, reducing to 4 per 100,000 for hepatitis B and 2 per 100,000 for hepatitis C. WHO previously had also released relative reductions, and these goals are also possible for countries to consider. In addition to these impact goals, WHO has established key interventions for enabling those impact goals to be met. And so these interventions include prevention, coverage of birth dose and 3-dose vaccine series, harm reduction coverage where injection drug use is a concern, blood safety and safe injections, and then also goals for testing and treatment, both for hepatitis B and C. Similar, if you're familiar with the HIV care cascade, although for hepatitis C, it's a bit different given that persons are cured of the virus, they then leave the cascade. So with all this in mind, the Coalition for Global Hepatitis Elimination, where I'm based, we exist within an NGO called the Task Force for Global Health that has a long history of helping coordinate global disease elimination programs, including for polio and other neglected tropical diseases like trachoma. We were launched in 2019 as one of the newest elimination programs to really learn from that collective history of disease elimination and support programs to come together to share lessons learned, data, discuss challenges, really push the movement forward by having that platform for governments to share with clinicians and civil society and to create new partnerships where they maybe didn't exist before. And so through the coalition's work, we've put together a framework for what are strong components of elimination initiatives, learning from that long history of other disease elimination campaigns. And what these components are 1, developing strategic national plans and monitoring performance, 2, catalyzing microelimination pilots, 3, implementing strong prevention, testing, and treatment policies, 4, mobilizing political and community support, 5, focusing on health equity, 6, integrating health hepatitis elimination services with existing health systems, 7, leveraging sustainable financing, 8 participating in operational research, and 9 revising targets as programs improve. So over the next few slides here, I'll walk through some of these select components and provide some data about what we know in terms of where countries and regions are globally and focusing on these components. We like to talk about these components and these policies because they're really about the building blocks to help engage and create strong, robust public health programs that can be then scaled over the time and enable those coverage targets in terms of measuring vaccine coverage or measuring testing coverage and measuring treatment coverage, which are very important, but those can only be achieved if these policies are in place. And I'd also like to recognize our director, Dr. Ward. Here's a citation here where he talks about really the formation of the coalition. He had this idea coming from US CDC that there was this gap in the global health architecture to have a home for hepatitis B and C elimination and create a technical hub for honing in on what these policies and key program elements are. And he would be with you here today if he could. Unfortunately, he's speaking at another World Hepatitis Day event. So some of the data I'm going to present is from 2 main initiatives of the coalition. One is a systematic review of national action plans that we conducted back in about 2019, 2020. The results of these action plans are available on our website in a searchable database. And here we've gone through and coded through the action plans and noted which plans have specific goals or targets or some of these essential policy components. We also have an initiative called the National Hepatitis Elimination Profile Initiative, which we call NHEP for short, if you see this acronym anywhere. And these are resources meant to pull together key epidemiological information, key data on progress towards elimination targets, as I showed before, but then go into depth on these policy components. And this is where we believe that NHEPs are a really unique resource in providing this policy analysis. And also not only looking at the quantitative information of, is this policy in place, has this goal been met, but also bringing the qualitative context on what have been recent achievements in that country, what have been new commitments from the government, what are new guidelines or policy documents from professional societies or other local groups, what are innovations and pilot programs that have the potential to be scaled up or replicated in other countries, and also outlining key steps and recommendations for pushing the program forward. Each of these profiles are developed in collaboration with Ministry of Health, clinicians, professional societies, civil society, and key partners, and we hope provide a comprehensive assessment of the situation in each country. So I'll be showing data from these profiles. So far, we've done about 30 profiles, about 6 in the African region, and this is where I mentioned we have not done a profile yet for Kenya, but hopefully this will be the spark to develop one in the future. So when we look at the action plan data in terms of the status of strategic information for hepatitis B and C and how many action plans there are, we found that only about 62 countries had national government endorsed action plans that set clear goals and targets and implementation strategies. This is much less than other sources cite. We believe this is because in many analyses, there might be looser definitions of what constitute an action plan, but we were really looking for clear, defined targets and goals that would help inform a government program. When we look at what type of impact targets and programmatic indicators are included in these action plans, we see that most of them include incidence goals, and very few actually include mortality goals. Programmatic targets, the most common are diagnosis goals, but harm reduction and other prevention indicators are much less common. When we look at the data from the 6 African region profiles we have developed, we found that Ethiopia, Nigeria, Rwanda, Senegal, and South Africa have all set hepatitis B and C elimination goals in their strategies aligned to the WHO goals, and their action plans are current. That means they've been updated recently. In comparison, Ghana had originally released one in 2014, but it has not been updated. So in comparison to other regions, actually, the representative sample of countries from the African region actually have quite strong policies on paper. Implementation is another issue, but in terms of policy development is actually quite strong in the region. And perhaps this is a learning from the major strides in HIV, malaria, and tuberculosis. When we look at systems in place, so moving from the policies in terms of strategic planning, but actually looking at the infrastructure at the government level to monitor progress on those strategies, we see that overall there's pretty poor infrastructure globally for hepatitis B and C mortality monitoring, new infection monitoring, surveillance systems. Very few countries are able to replicate serosurveys on a routine basis to have accurate estimates of burden of disease. And only about a third of countries have systems to track the number of persons tested and treated for hepatitis B, and about 45% for hepatitis C, a little better for hepatitis C. So as the world scales up elimination efforts, strengthening these systems is very important to be able to know when we're actually getting close to elimination in the first place. When we look at the African region, mixed trends, as we saw globally in terms of mortality, only Rwanda has a system to be able to track the number of persons dying from hepatitis B and C related causes. For incidence is also very difficult to measure, and some countries are currently piloting systems. And then prevalence, we do see that some of the African countries have more robust estimates than other parts of the world because they've been able to integrate hepatitis B and C into some of the HIV surveys or other surveys that have been ongoing, which is a creative strategy that we think other parts of the world could learn from. And as we talked about in terms of a monitoring system for testing and treatment, only Rwanda really has this in place in the African region right now, but other countries are starting to pilot initiatives, including Nigeria and Ethiopia are both launching national systems to look at how many people have been tested and treated on a regular basis. Here's an example for just a different part of the world. This is a screenshot from our profile for the country of Georgia, which is a global leader in hepatitis C elimination. And this is very typical of a country globally in terms of looking at the reporting systems. Mortality is difficult for most countries to be able to collect, given that most death certificates often do not include the hepatitis B or C infection. They may say liver cancer or cirrhosis or another liver condition, but perhaps they don't note the hepatitis B and C to trace it back to that. And then in terms of incidence, given that hepatitis B and C can be undiagnosed for many years, measuring incidence is very, very difficult since most patients are asymptomatic at the time of infection. But innovative approaches like in Georgia are being developed, including sentinel surveillance sites, and WHO is developing guidance on this to help countries. And then prevalence, Georgia has conducted seroprevalence studies on a regular basis with the support of US CDC, and this is very important as they hope to be a leader to demonstrate their progress. They have not conducted economic evaluations, which are important to understand and make the case to the treasury departments in a country. But there they've been fortunate to have other sources of financing for treatment. And then on monitoring, they have a system for hepatitis C, but not yet for hepatitis B, which is another common trend we see. So moving to policies for prevention, testing, and treatment. On the prevention side, just want to emphasize again the real emerging trend of hepatitis B burden being driven by mother to child transmission. It's projected that by 2030, about half of all new hepatitis B cases will be due to mother to child transmission. And this is important given that the coverage currently of hepatitis B birth dose vaccine is only 6% among African newborns. And birth dose is really the pillar of the prevention of mother-to-child transmission strategy put forth by WHO. This pyramid here is the different interventions you can layer to increase the protectiveness of the infant to that transmission. So the base here, we have vaccine coverage, shows 3-dose coverage, which most countries are doing well. And then we have birth dose, so vaccinations really that foundation. Then we have screening of the pregnant woman for hepatitis B infection. And then we have HBIG, which can be given after birth to the infant. And then we have tenofovir for women who are found to be HB surface and hepatitis B surface antigen positive, and they can be put on tenofovir as prophylactic treatment. When we look at the status of implementing some of these most core policies of birth dose vaccination and antenatal screening, about 2/3 of countries globally have indeed adopted that birth dose vaccine. The partially adopted is due primarily to the majority of countries in the African region that have not adopted this, and then also some countries in more low and endemic settings, they have selective policies where they'll only vaccinate the children born to mothers that are positive for hepatitis B surface antigen. But this strategy only is effective if you have really robust screening policies and programs in place. When we look at antenatal screening, this is much higher, at over 80% of countries having screening for hepatitis B. When we look at screening of pregnant women for hepatitis C, less than half of countries currently have this policy in place. Hepatitis C vertical transmission is possible, but is less common than hepatitis B. And so this table here just shows again this gap in the African region of this adoption of hepatitis B birth dose policies, and also adoption and implementation of hepatitis B antenatal screening. We believe this is a huge opportunity given the robust HIV antenatal screening programs in the region. To add hepatitis B should be very cost effective for governments to take on. On the hepatitis B birth dose side, this slide is a summary of the findings from the profiles in the African region. And this was developed back in November, but I do have good news on birth dose, and that just last month, Gavi, the Vaccine Alliance, finally lifted the pause on support for hepatitis B birth dose. This was the reason many countries have cited in the African region for not introducing birth dose. They were waiting for Gavi to make support available and include birth dose as an eligible vaccine. This had been on pause during the COVID-19 pandemic, and it was unclear when that was going to change. But this was a really exciting development, and we hope will lead to additional adoption in the future. Nonetheless, we've seen initiatives underway by a number of countries, even in the absence of Gavi support, to move forward. Ethiopia has been currently piloting a birth dose program in one region in the capital city. And then we've seen that Ghana and South Africa have gone ahead and approved policies, but haven't necessarily implemented nationally. And then in Rwanda, we saw a targeted approach for birth dose to infants born to mothers born positive for hepatitis B surface antigen. And this is so important because we know birth dose works in terms of reducing prevalence of hepatitis B among children under 5. These are examples from countries around the world in select regions of showing what the prevalence of hepatitis B was before and after the introduction of birth dose, and it's over 90% in most cases. Projections show that if hepatitis B birth dose were to be scaled up in the African region, over 500,000 deaths could be prevented, which for this cohort born from 2020 to 2030. So on this topic, the coalition has a number of resources and initiatives to support this policy development, particularly in the African region. We've hosted a number of webinar series, and all these recordings are available on our website to share challenges that governments are facing in terms of finding the resources to implement this policy or adopt this policy in the first place, to make the case to their national immunization technical advisory groups. We've also discussed on these webinars the challenges with home births in the region and other operational issues, and that the vaccine is often delivered by a midwife at the time of birth versus other vaccines are delivered by other healthcare workers and managed more by the EPI program. And so talking through those logistical challenges. And we hope these meetings will continue in the future, especially with the expected increase in number of countries adopting this policy. We've also funded a number of civil society organizations in the region. Here's a poster in the middle from a group in Uganda. And there we believe that the civil society activism around this issue led to the Ugandan government approving a birth dose policy and planning for rollout. And we hope that this civil society and program will continue this fall, and we'll have another call for civil society organizations to apply for funding to work with us. And then on the right, on the more technical side, last year, late in the year in December, we published a resource particularly focused at these national immunization technical advisory groups that make national policies on vaccine recommendations that include, we believe, all the evidence they need to make the case for including birth dose. And so this resource includes burden information, everything about the vaccine in terms of effectiveness, equity concerns, economic considerations. And we hope this is not only a tool, though, for these groups, but can also be used as an informative guide for other stakeholders as well, including clinicians and public health officials. And that's also available on the coalition's website. Here's just another beautiful display of some of the civil society groups that we've been working with on promoting birth dose in the region. On the top left there is a session from Ghana, training of midwives on hepatitis B birth dose vaccination. On hepatitis C and prevention of mother-to-child transmission, our work at the coalition has really focused on looking at the one group that currently does not have an indication for hepatitis C treatment. There is no US FDA approval of hepatitis C medicines among pregnant women just because they have not been included in any of the clinical trials. And so we believe that this is a real urgent remaining gap in the hepatitis C public health approach, and that we're not able to screen and treat pregnant women like we would be for other infectious diseases. And so to combat this gap, the coalition had worked with the US CDC to create a program we call TIP Hep C, treatment in pregnancy of hepatitis C. And this is an initiative to help collect that evidence to inform provider and patient decision-making around hepatitis C treatment. Right now, there's no reason to believe these medicines are not safe in pregnancy, but we just don't have the large-scale clinical trials to have those formal recommendations. But there are a number of cases where women have started hepatitis C treatment and then become pregnant. And so an accidental exposure, or in some cases, providers and patients have made the decision to go on with treatment without the lack of a formal indication, because they believe the risk of transmission could be high, or that is just the most convenient time for a woman to accept the treatment given her access to healthcare. So in an effort to collect these cases and compile these experiences globally, the coalition has created a registry, which you see a QR code on the right here. And this is a global registry really trying to compile data from across the world. We launched this last year and it'll continue in the future. And so this is just a shout out that if you are aware of any of these cases, we would invite you to contribute them to this global effort. We've also run a number of community of practice sessions on this as well, and these webinars are on our website. When we look at harm reduction, we see that most countries have not made as much progress on the harm reduction side. Coverage of needles and syringes for persons who inject drugs is quite low, and this is true for the African region too, as a summary of those profiles. Moving to testing and treatment, we see that about 10% of persons living with hepatitis B have been diagnosed globally and only 2% treated. For hepatitis C, about 20% have been diagnosed globally and only about 13% treated. And on the testing side, there are a number of barriers to diagnosis of why we see that most patients are unaware of their status. The first being that the algorithms are very complicated. So this is an hepatitis C example, but many of these same patterns are true for hepatitis B. Patients have to come back for multiple steps of testing, first antibody testing, and then confirmation of exposure and virus detection with PCR testing. Often this can be requiring laboratory visits. We see that the cost is a major barrier, especially for PCR testing. And so we really need better tools and diagnostics to have point of care options for hepatitis B and C that are very affordable. For hepatitis C, we do have antibody point of care tests, and we also have gene expert PCR point of care tests, but in many cases, these gene expert machines are in the place for tuberculosis or HIV testing, but the hepatitis C programs are not able to access them. And so when we look at policies for hepatitis testing, the majority of countries do not have universal testing recommendations, which are often needed in generalized epidemic settings to get to elimination. Most countries still only have risk-based policies. We also see that less than half of countries have removed copays for patients, making it very unaffordable to access testing. And then as discussed on PCR testing, only about half of countries have options for point of care PCR testing, thinking of the gene expert in particular. When we look at the African countries profiles, we saw that the majority still have risk-based recommendations for hepatitis B and C screening, meaning that only groups that are thought to be at the highest risk of exposure should be tested, including key populations such as persons who inject drugs, persons with a history of tattoos, history of blood transfusions, and similar blood exposures. We did see that Rwanda and Nigeria have recently implemented or adopted, I should say, hepatitis B and hepatitis C universal screening, meaning one-time screening for the entire population, but only Rwanda has implemented this to date, and Nigeria is still planning for scale up. On the treatment side, the good news is that price really should not be a barrier for any country. We see that the generics for that most countries in the African region in particular are eligible for, the prices have come down substantially since the drugs were first released. So now over 60% of persons living with hepatitis C are in generic territories where the cost of treatment is less than $150 US at the time of making this slide, and it continues to come down as low as $60 or less, US dollars or less in many countries. And so with the cost of treatment no longer really being the barrier, we are very focused on these other policies that are preventing patients from accessing treatment. This includes treatment not being available where patients are. This includes restrictions in treatment guidelines, prioritizing treatment only for patients with advanced liver disease or advanced fibrosis staging, requiring patients to be abstinent from drugs and alcohol to access treatment, and then simplifying that care algorithm, reducing the number of diagnostic tests, reducing the number of clinic visits, when possible, implementing a practice called reflex testing, where you remove the need for two different diagnostic steps, the screening for hepatitis C, for example, the antibody screening and the PCR testing where possible, collecting the samples all in one visit or having all point of care testing, just to be able to reduce the time it takes to get a patient to initiate treatment. And then even if the treatment costs and procurement have come down, in many cases, patients are not seeing that covered by national health insurance schemes, or still the out-of-pocket cost can be unaffordable to most patients. So globally, this is a lot of information, so I won't go through it all, but just to show you that we are monitoring in these profile countries, which countries are adopting these policies. We see that the majority of countries have developed national treatment guidelines, and the majority of these guidelines have removed these fibrosis and sobriety restrictions. We still see that many countries, though, require genotyping in their guidelines, which is an unnecessary diagnostic step. In most cases, there are patients that do require this, and they should be referred to a specialist. But we do have pan-genotypic medicines now for hepatitis C. And so these patients, most patients should not require genotyping, which can be an expensive test to add. We also see that only half of countries allow non-specialists to prescribe hepatitis C treatment. We have a plethora of evidence to show that primary care physicians and other physicians and even other health professionals can safely administer and monitor patients. The hepatitis C treatments are so easy that there is no need to refer patients to specialists. And on the hepatitis C side, we see a similar trend that most algorithms currently adopted in clinical guidelines are not written in a way to promote primary healthcare management of hepatitis B patients, creating a barrier in access to not meeting patients where they are. Only about a quarter of countries currently have a primary healthcare component to their guidelines. And for treatment copays, a similar story, only about half of countries have removed copays for patients. So when we talk about which countries have made progress, it's really, I think, a disparity on hepatitis B and C to note here. The examples I pulled are really on the hepatitis C side, because we have these amazing cures that can be given to patients in a very short duration. Many countries have taken the opportunity to eliminate hepatitis C much quicker than hepatitis B, given that there we have a vaccine, but for patients already infected, treatment is lifelong. And so that burden and commitment has been harder for governments to take on, but is the next frontier. But on hepatitis C, we see that countries like Rwanda, with not a lot of resources, have just made it a national commitment to eliminate hepatitis C. Just in the past few years, since 2015, over 6 million people in Rwanda have been screened for hepatitis C, and over 50,000 persons treated. They estimate over 95% of people living with hepatitis C have been diagnosed, and they've been able to do this largely by building on the back of their HIV program. Egypt, when you Google hepatitis C, will most certainly come up. They've been really the global leader in hepatitis C elimination. They very quickly screened their entire population, over 20 million persons a year. In the bottom left is a picture from their profile showing that that they were able just to achieve remarkable numbers, over 4 million people treated over 6 years. And they estimate that over 96 persons living with hepatitis C have been diagnosed. So Egypt has really been one of our best case studies for hepatitis C elimination. It really started with political commitment and the government at the presidential level saying we are going to do this. Then other enabling factors included reducing the cost of those tests and treatment to make it affordable for the government to finance this, and then really taking a public health approach, decentralizing testing and treatment, going to communities, meeting people where they are, creating a network of treatment centers to refer patients to, And the results are clear that this worked. This is just another graphic just showing how they were able to create a very coordinated national public health approach program to reach the levels they did. And this is expected to have massive public health and economic gains just from their treatment program to date. They believe that they've reduced hepatitis C deaths by about 60% by 2030 compared to what the trend was in the absence of this treatment program, and averted 250,000 hepatitis C related deaths by 2030. So I know this has been a tour de force, so I promise to be wrapping up so we can get to questions, but just quickly on a few last of these key components I don't want to leave out given how important they are. Equity, we know, must be at the center of every disease elimination initiative or every public health initiative. We see that in hepatitis that the majority of action plans developed have learned this lesson and do indicate that it's important to address stigma as part of the national strategy. Though most patient experiences qualitatively say that all countries have a long way to go to addressing the burden of stigma facing persons living with hepatitis B and hepatitis C. In terms of a country making good strides of centering equity, Canada is a very good example of recognizing that the majority of persons living with hepatitis B are immigrants in Canada, and the majority of persons living with hepatitis C are persons who inject drugs. And so recognizing that there is a need to really promote access of services for vulnerable populations. So their strategy includes these key populations at the core of it. They've partially adopted laws preventing discrimination against persons living with hepatitis B and C. They've looked at expanding hepatitis B vaccination for adults. There's a big emphasis on childhood vaccination, but for groups most affected, adult vaccination is also important, especially to reach those persons who did not have access to the vaccine as a child, and then a robust harm reduction strategy to reduce the risk for persons who inject drugs, including that there's syringe exchange in federal prisons. This is a policy not routinely adopted globally, but Canada has been a leader in this way, and ensuring, just like testing and treatment services, that there's robust national access to syringe exchange and opioid substitution therapy for persons who use drugs. And then the last component I'll talk through is just the financing. Of course, none of this is possible unless there are budgets to support it. In our review of national action plans, only about a third of them included cost estimates and a budget plan for actually implementing them. So there is a ways to go in terms of making sure these really pretty strategies with all the right components are actually executed. But there are some examples of countries creating a path to scale up those budgets. Unlike HIV and tuberculosis and malaria, there is no global fund, there is no PEPFAR for hepatitis. There are a few small philanthropic initiatives. There's an organization called the Hepatitis Fund that gives out some grants for hepatitis, but we know that hepatitis elimination will have to be achieved in partnership with governments, using some external financing to catalyze further progress, but governments have to be committed to this and really be committed to integrating hepatitis into their universal health coverage schemes, their primary healthcare initiatives, and that is how we're going to finance and achieve these hepatitis elimination goals. So the majority of countries that we've looked at have made steps to create a budget for hepatitis B and hepatitis C. The problem is often these budgets just aren't large enough to finance programs at scale, with the exceptions of the countries I've mentioned so far. Rwanda has achieved massive increases in hepatitis B and C. It's very close to elimination of hepatitis C, and they've done this in a combination of domestic funding and leveraging global fund and HIV resources when possible. Other countries such as Italy have created innovative screening funds to support massive scale up, and we need to take these lessons and scale them. So this is just a summary of the African country profiles that we've looked at. and showing that some of the roadblocks some of the countries in the region face in terms of finding budget to procure tests and medicines at scale, adding these services to national health insurance schemes is a major priority in a country like Ghana, really establishing a budget for the first time. So just to summarize it in brief, there is really a huge opportunity in public health, a once in a lifetime, once in a generation chance to eliminate this highly prevalent, highly deadly twin diseases in hepatitis B and C. And to make those elimination goals possible, we know what works, we know the policies that must be in place, and it's really about helping countries put in each one of those components at a time and build on their progress. And we see that there is progress to celebrate. This is a long journey, and there's certainly more to do, but we have examples of success, and we must recognize those achievements to inspire others to commit to this elimination journey. It is so important to share these lessons learned. We believe that sharing innovations and approaches will only accelerate actions across countries. And we have to make sure that we're tracking our policies and our progress to understand where the gaps continue to be, how to better direct resources, how to prioritize partnership development and research, and also to be able to ask for new funding in those areas. Funding still remains a gap and will consistently be a challenge, but the coalition, we're committed to forming new partnerships and working together to identify new resources to bring to countries to implement elimination initiatives. And on the policy side, we really need to focus on surveillance, hepatitis B birth dose, testing recommendations, ensuring that countries are moving beyond risk-based when the burden of disease warrants that, ensuring access for key population to prevention services, reducing costs of testing and treatment for both B and C, decentralizing both hepatitis B and C testing and treatment to the local level, and ensuring equity is at the center of our approach. So thank you so much for the opportunity to present today. If we have time for it, I have a few more slides on resources from the coalition that may be of interest, but I'll stop here so we can open it up to questions. Thank you.
Okay, thank you very much, Lindsay, for that excellent presentation. It was very informative. You've given us quite a global perspective. Just to remind the attendees, Lindsay mentioned she's not a clinician, so her approach to hepatitis B is more from the public health perspective. So programs, policy, data, and research. And so your questions should be aligned in that direction. So maybe I can go to the Q&A. There are several clinical questions.
Thank you so much, Fee. I was just going to respond on the clinical side. I'm happy to take down these questions and share them with my team. We do have clinicians on our team that I can share those questions with and revert to you at a later date. I don't have the expertise myself to respond to that.
Okay, thank you for that clarification. So I'll just move to the questions. So there's a question here. Being a viral disease the cost of management is extremely expensive. So what are the strategic measures to avail drugs for hepatitis B and C ailing patients for free, just like the HIV ones are available?
Yes, very good question. And unfortunately, the treatments should not be expensive to patients. The price should be under even $80, $60 for a case of hepatitis C. And really the problem is the procurement and ensuring these drugs are on the National Essential Medicines list and available to patients for free. And governments can come up with innovative strategies to finance these initiatives. We know it's cost saving in the long run for governments to provide this treatment because it prevents the onset of severe liver disease and liver cancer, which is much more expensive to treat over the long term than one-time hepatitis C cure. But still, it can be hard to make that case, and we're still working to ensure that that economic argument is understood by most governments. So in the absence, there are ways that we can leverage the HIV programs, for example. It's not a perfect solution for all patients, but the Global Fund has recently expanded its programs and inclusion of hepatitis initiatives. And so particularly around screening of hepatitis B and prophylaxis for pregnant women, and then also for key populations, the inclusion of hepatitis C testing and treatment. So that is one option that we currently have available, and we should continue to advocate to include general population hepatitis screening and treatment for these global initiatives, because hepatitis is very neglected. It doesn't have a home, and given the burden, it really should. And so I think everyone can work together to encourage global health organizations to take on hepatitis, I think would make a huge difference in making it more accessible. On the hepatitis B side, it's similar. In many cases, tenofovir is available in HIV programs for free, but not available in hepatitis B programs. And that makes no sense, I think, to most people working in hepatitis, and it's just a siloed vertical program approach. And so it's really an advocacy question of either lobbying governments or funders to ask why these drugs can't be available for other patients that need them when they're just as life-saving for those patients.
Yeah, thank you for that answer. So there's another question here on the vaccine schedule. You had mentioned the hepatitis B birth dose and that you're advocating for this. So what the question is whether this is added on top of the usual schedule, the hepatitis B vaccine doses that are given at 6 weeks, 10 weeks, and 14 weeks.
That's correct. Yes, this would be in addition to the regular 3-dose schedule that all countries have adopted and have achieved fairly high coverage of. And this is within 24 hours to be most effective. And it's really targeted at that prevention of mother-to-child transmission. The 3-dose does have some impact, but really is most effective at that horizontal transmission and protection later in life. And any other questions you have on hepatitis B vaccination, our director, formerly, as I mentioned, Dr. John Ward he was at US CDC, and he's written book chapters on hepatitis B vaccine. Is very much a global expert. So please, I will put my email in the chat, and if you have any other questions, I would be happy to pass them to him, and he would gladly respond.
So there's a question here, which I don't know, maybe more clinical. Someone is asking, where are the hepatitis B vaccines manufactured? Are they mRNA technology?
That's a great question. I don't believe they're mRNA technology yet. I'm sure that's being explored. There are a number of manufacturers globally, a number of generic manufacturers, but I'm happy to follow up if you have an interest in the company names. Right now, hepatitis B vaccine is part of the pentavalent vaccine, so Gavi procures that, and then birth dose is a monovalent vaccine.
Okay, thank you. So there's a question here about, they're asking about data from Kenya. They're asking, where does Kenya rank globally in adoption of vaccination according to your programs, according to the data that you've given?
That's a great question, and I wish I had more data on Kenya to show. I hope I'll be able to collaborate with perhaps some of you on the call to fill those gaps. So we have not done a full profile or evaluation of the situation in Kenya. My understanding is that there is some interest in developing an elimination program in Kenya, but it has not been nationally launched. And so I have not seen a national strategy, but perhaps you're aware of one you can share with us and we can add it to our database. And so I think for Kenya, they're really at the early steps of creating the foundation of what an elimination initiative could look like, solving these questions around access to testing and treatment, which parts of the HIV infrastructure can be leveraged. On the key population side, there has been a tremendous work. I think Kenya is a regional leader in looking at access of hepatitis C testing and treatment and prevention for persons who inject drugs. And so I'm aware of studies, especially in prisons, of looking at models of care for persons living with hepatitis C in those settings. But in terms of a national initiative, I think there is room to grow, and we'd be happy to work with anyone on that.
Okay, so there are a lot of clinical questions, but I'll just remind you that Lindsay had mentioned she's not a clinician, and those can be answered later. So there's a question here on whether the pentavalent immunization has produced any results in reducing probably the prevalence of hepatitis B.
Yes, there is large data sets showing this, particularly in East Asia, particularly Taiwan, which was one of the first adopters of a pentavalent vaccine or hepatitis B vaccination overall, given the high prevalence in that region. And just incredibly convincing data. I'd be happy to share with you the article showing the reductions in prevalence over time. And I have one slide, I can bring it up perhaps while the next question is coming up, showing the reductions in prevalence in countries that have adopted vaccine series. But it's over 90%.
Okay, so while you're bringing that up, there's a question here about hepatitis B vaccination. So they're asking, after receiving 3 doses, is there a need for people to get boosters thereafter?
Yes, this is a question that I will certainly follow up with as well and confirm with our medical team. But my understanding is that in most cases, hepatitis B immunity maintains, but in some cases it does decline over time. And so especially for persons that are potentially at risk of exposure, there is a recommendation for a booster.
So I can see your slide.
Yes, I can zoom in here. So this is the slide showing changes in hepatitis B surface antigen prevalence before and after hepatitis B birth dose and the 3-dose series has been introduced. So in a country for like China, for example, 10% to 0.3%.
Thank you. So there's a question here from Felicitas. She's asking, are there population-based approaches from country programs that you know of to avail hepatitis B specific immunoglobulins, which are recommended for babies who are born to hepatitis B surface antigen positive pregnant women, so that they can get this in addition to the hepatitis B vaccine birth dose? Because from her perspective, hepatitis B immunoglobulin is currently barely accessible in Kenya. Yeah.
Yes, a very good question, and a major obstacle right now from a public health approach, that immunoglobulin is very expensive and difficult to procure. And Thailand is, I think, the best example of a robust elimination of mother-to-child transmission program, and they currently offer HBIG. But there is research ongoing to see if there are other approaches, given that in most low resource setting, HBIG is very difficult to access. So this is, I think, a developing part of public health, but really the core of the approach is birth dose, which is very affordable, very accessible. If the country has included in the vaccine schedule, and then the 3-dose series, and then testing and treatment of the pregnant women. In many settings, it is more feasible than HBIG.
Okay, so another question is regarding the success stories that you mentioned. You mentioned Georgia, Egypt, Rwanda being on the road to elimination. So just to clarify, are there any countries that have actually eliminated hepatitis B and C?
No country has been officially certified yet. WHO just this year released the process for how a country could go about applying for certification of elimination status. And they've defined different bands on the path to elimination, gold, silver, bronze. And so countries are currently right now in discussions with WHO of applying for those different certifications. But my understanding is that Egypt, Rwanda, and the country of England are all quite advanced. Other case studies, though, include Mongolia, of course, Rwanda, as discussed. Australia has made terrific progress. So really in all regions of the world, we've seen a few early adopting countries that hopefully will inspire other countries to also improve. Just one other regional example to mention, we've been collaborating with the government of Ghana and helped facilitate a donation from an Egyptian manufacturer of hepatitis C medicines called Farco. And there, those medicines were donated to Ghana, about 50,000 courses. And we've been helping the government and a coordinating committee establish their first national treatment program. And so the challenges with the prices of testing are still very much there. And the long-term plan for financing treatment still needs to be worked out. But we've seen that innovative catalytic approaches like this, where you can secure a donation to start the program, hopefully will lead to a follow-on effect of continuing the elimination progress in the future.
Thank you. So there's a comment here, an anonymous attendee who says, great presentation. So they're asking, is it true that most public health programs, they're saying, sorry, it is true that most public health programs in Kenya have been implemented vertically, and they are thinking that leveraging on the HIV infrastructure might be a great way to expand the hepatitis programs, because HIV has robust commodity and service delivery systems, which are already decentralized. So you don't need to have another parallel hepatitis B program. So they are saying there's a need to improve access to hepatitis B screening tests beyond people with injectable disease, and to structure sustainable management. Maybe more of a comment on a question.
Yeah. That's a great comment, and couldn't agree more. In countries with strong HIV programs, that is a very feasible approach. That is what Rwanda has done. Now South Africa is looking to also build on their HIV program. And the main challenge there is more political in advocacy, given that the funding is siloed in many cases. It really has to come from the top, the desire to integrate those programs, but the approaches are often the same in terms of screening. When we think about antenatal screening and prophylactic treatment, when we think of just general population screening and different approaches to screening and HIV, there's been a huge movement to simplify treatment and the algorithm, and we see that for hepatitis B and hepatitis C. The laboratory equipment can be shared, but it's really just a silo of program management and funding that needs to be broken down and really just a change in paradigm. So I think that's something we're always trying to promote, and always looking for local champions, because it starts at the local level. We've been working with a project in Pakistan, and it was one local champion who just really felt like nothing was being done on hepatitis and knew there was a high prevalence in her community. And so she went to the district Ministry of Health office and encouraged them to start a program. She looked at the available resources, saw that there was a lab, in this case for COVID, that was being underutilized. And she was able to integrate hepatitis testing into this COVID laboratory, given that the machines were very much the same that could be used for both diseases. And so that creative mindset of trying to break down those silos and integrate health programs is really what's needed.
Okay, so just one more question. My question is around equity. So you know that hepatitis B is more prevalent in the LMIC setting, the low and middle income countries, and hepatitis C in the high income countries. So there's been a lot more, it looks like there's been a lot more research into hepatitis C, and we have a lot of these new drugs that have come out. So I don't know, is there any work into encouraging more research, more focus to be made onto hepatitis B viral treatment? Yes.
That's a great question as well. And I think now is the pivotal time for hepatitis B. WHO is set to release new guidelines for hepatitis B later this year, which we are hoping will be a simpler approach. For too long, the hepatitis B guidelines have been too complicated to implement in most settings with all the diagnostic criteria, very difficult to decentralize. And so it's been very hard for countries to take public health approaches, especially in LMIC settings. And so WHO is aware of that and following in hepatitis C's footsteps, trying to build on that momentum. They are planning to release these new guidelines, which we are all waiting for at the end of the year. I think that there'll still be work to be done. There's been a lack of investment in research in hepatitis B as well. We believe that functional cures are on the horizon, but still 10 years out or so is the current projection. So in the meantime, we need to look to use the tools we have in terms of screening and treatment, because we know that treatment still is very effective in reducing likelihood of severe liver disease. And so we're actually working at the coalition on a report that will be out in a couple months on a research roadmap in terms of what operational questions need to be answered to be able to get to a very simple approach of managing and monitoring hepatitis B patients. So please be on the lookout for that. That should be coming, and we'd welcome anyone's input, especially if you're working in this space at all. Because there's very few examples of national hepatitis B programs like there are for HIV, and we'd like to work together to be able to document that and be able to create those models of care that others can adopt.
Okay, thank you so much, Lindsay. I think we are at the end. There are no other questions. So just to say, to some of the comments, there are a lot of emojis there saying thank you. Thanks for the insightful presentation and for that great effort towards hepatitis elimination. For the attendees who are asking about CPD points, the KNH team will ensure that you get them. So Lindsay, I don't know if you have any parting shot before we wind up.
No, I just want to thank you all for your interest and for attending today. Happy World Hepatitis Day. My email's in the chat. Please don't hesitate to reach out, and I'm happy to connect you with anyone on our team or our network of clinicians and government officials working in the Coalition on Hepatitis Elimination if you're interested in getting more involved. There is a Society on Liver Disease in Africa that was just launched this year, and that perhaps might be of interest to some of you. And I think we'll see more to come on hepatitis B and C elimination. Thank you so much.
Okay, thank you. Thanks again. So for the attendees, the webinar will be made available on the KNH website. Then just my last comment is just to make sure you're tested for hepatitis B, know your status, and make sure you're vaccinated. Thank you all for attending, and enjoy your evening. Goodbye. Bye.
Thank you so much.